we're going to talk a little bit about examining the pediatric patient, what normal and abnormal x-rays of the elbow look like, and then some of the very common pediatric upper extremities fractures. These aren't all inclusive, but we'll talk briefly about clavicle and proximal humerus fractures, and then spend a lot of our time on supracondylar fractures, both bone forearm fractures and distal radius fractures, which are kind of bread and butter pediatric orthopedics. So in pediatrics, compartment syndrome, like you've learned in other lectures, I'm sure through this series, the 5 Ps aren't as applicable, but rather the 3 As. And we do think about this in the forearm fractures especially. So look for agitation, anxiety, and increased analgesia, as some of the patients can be otherwise harder to pick up on compartment syndrome. And then do think about NAT for all children, especially non-ambulatory children. We'll start with clavicle fractures, and again, moderators chime in at any time if you like. This is the most common fracture in the newborn, and it can be associated with brachial plexus injuries. These heal without any intervention other than usually just an ACE wrap to the body. Proximal humerus fractures are less common fractures, but also have a high potential to remodel, being near the physis, and can usually be treated non-operatively. Here's an example of a bad proximal humerus fracture. This was shared with me by one of our mentors, and you can see with just a hanging arm cast, it reduced nicely and did not require surgery. So pediatric elbow anatomy. This is a good question for tests, and something that is good to know when you're looking at x-rays. Just when do the ossification centers of the elbow appear, and whatever mnemonic you want to use, go ahead and get one so that you know what to be looking for on those x-rays. Also, something important to look for is to make sure that you always know that the radius bisects the capitellum, which would be a line along here, and that the anterior humeral line should bisect the capitellum. In children older than 4, it might be a little more anterior in young children. Some basics here. Always make sure that the radial head is pointing through the center of the capitellum, as you don't want to miss a Montasia fracture, which is a radial head dislocation associated with an ulna fracture. Here's an example from one of my mentors of just ER consult for possible olecranon fracture, and is this OI? And as you can see here, the radial head does not pass through the capitellum, so you don't want to be distracted by other things that someone else might think is a fracture. Always start with the basics and look at your x-rays. The other thing to look for is when you don't see a fracture, make sure you're looking for the fat pad sign. So there's 3 fat pads of the elbow: the anterior, the posterior, and the supinator. The posterior fat pad sign is what we're usually looking for fracture. And again, another Skaggs paper just saying that if there is a posterior fat pad sign, that there's a 76% chance that there's a fracture, the most common being a type 1 supracondylar or a radial neck fracture. So pediatric supracondylar fractures, this is sort of bread and butter. Again, peds ortho, it's the most common elbow fracture, and we commonly see it in ages 5 to 7, but really in any age group. And the mechanism is usually just a simple fall on an outstretched hand. So these are the things of just, playing on monkey bars or falling down. And most of them are extension type fractures, 90%. So if you ever have to guess that it's an extension type. Usually you'll see a painful and swollen elbow. Sometimes you'll see a dimple in the front of the elbow, and that can be where the humerus is actually buttonholed through the brachialis muscle and cause some puckering of the skin there. It's good to do a good neurovascular exam. Sensory and the motor component of the median nerve, and oftentimes just the motor part will be out. So even though sensation is intact, sometimes patients will just have an AIN entry, which is the OK sign. Which what are you testing when you're doing the OK sign? So we'd be looking at our, when you're making the OK sign, FPL. Yep. Okay. And then FDP to that index. Great. Okay. And then so that would be the most common injury there would be the AIN and testing for median nerve, but also test the radial nerve with a thumbs up. And then the ulnar, you can have them abduct or adduct their fingers, or most commonly just cross the fingers. It's easy to test. And then also check the sensation in those ulnar fingers as well. Okay, great. So there's a pretty high rate of injury that you can, depending on who literature you look at, but at least 11% rate. And there's some Boston papers that report up to 20 or 30% rate of nerve injury. And usually we simply just observe these nerve injuries and they're present before surgery and after surgery. The only thing that is important to get a good neuro exam beforehand to make sure that it hasn't changed afterwards, as that can be more concerning. Okay. All right, vascular examination. We would always check for a radial pulse, and we can Doppler it if necessary, but a warm and well-perfused hand is a good sign. There's a lot of questions that have been asked on tests about this particular scenario, and there's been different answers over the years. But in sense, if you don't have a good radial pulse and the hand is cool, that's certainly an emergency. But if you have a warm and well-perfused hand and you can't find a pulse, that usually just means it's an urgent reduction, and it may mean the artery is simply in spasm. So the timing of that is a little more controversial. Jason and Rob, what do you do if you have a warm hand without a pulse? Let's move on here. So again, we talked a little bit about x-rays already in this anterior humeral line. It should bisect the capitellum. Certainly would be encouraging if the hand is warm and has a Dopplerable pulse and good perfusion. I don't think I would use that in and of itself as the only means of testing perfusion. And for me, I have a pretty low threshold personally, just to take somebody to the OR if they have also a nerve injury along with questionable pulse, simply because those two structures are so close together. What in terms of radiographs, we're going to get orthogonal views. We talked about an AP and lateral of the elbow, and then on this lateral x-ray is usually where for more minor supracondylar fractures, this would be one of the things we might be using to decide if the patient needs surgery or not. And then again, a posterior fat pad sign would be for the most mild of fractures, which would suggest a non-displaced fracture. So we classify pediatric supracondylar fractures in 4 different categories. The first would just be the non-displaced, which is that posterior fat pad sign or a subtle fracture without any change in the anatomic position. A type 2 is displaced and angulated only in the sagittal plane with an intact posterior cortex. And then a type 3 is completely displaced, so a displacement in both the coronal and sagittal planes. And then a type 4, which was added later, not by Gartland, is unstable in both the coronal and sagittal planes, and that is usually something that's just made intraoperatively, but is kind of something that's reported certainly in the literature when talking about different types of supracondylar fractures. So for type 1s, this is something we see a lot of in our clinics. Maybe at some places, an APP may even see a lot of these fractures, or even in a resident clinic, you might be managing them, or anywhere you're helping out, but would just be treated with a cast for between 3 and 4 weeks. And Jason also added here, when we were reviewing these slides, the AOS has some nice clinical practice guidelines for supracondylar fractures, given this is such a common fracture. Type 2 fractures, usually treatment can be just a cast, or a lot of times it's CRPP, which is closed reduction percutaneous pinning with application of a cast. Most older children who have less potential to remodel will get pinned, but for the very young with very minimally displaced fractures, there can certainly be an argument for not treating these with surgery and just treating with a cast. And many people say 2 pins for a type 2, 3 pins for a type 3. And then again, the same amount of time to heal irrespective of the type of fracture, so about 3 to 4 weeks. A tight point is the elbow is doesn't have a lot of growth there. Much of the humerus growth occurs from the proximal humerus. So whereas we'll talk about in the distal radius, we allow a lot of angulation in the plane of motion, there isn't as much potential to remodel for the elbow. So the rotation can't remodel, but the flexion extension can. And Dr. Gamble from Stanford does have a pretty good paper about remodeling in type 2 fractures. So some people would say some are too aggressive about treating these, and some think that, it's a pretty easy and quick surgery to do to make sure that we restore anatomy. But certainly there is some potential to remodel, especially the younger the patient. So I think the jury is still out on exactly, and there may be some center dependent factors there as well. So type 3, not so controversial at all in terms of its treatment. Everyone would really get a closed reduction in pinning, or possibly an open reduction if a satisfactory reduction can't be done via closed means. And the size of wire, there's from Boston about what size to use, but 1.6 or 2 millimeter wires generally for most patients, and then placed in a cast for 3 to 4 weeks. These pins are typically put in from lateral. And we talked a little bit about timing. These are sort of the bad fractures, as you can see on this x-ray. There's a lot of displacement here, so the neurovascular structures can be tented or put on stretch. So delaying the case is that important, and there's been multiple papers showing that you have literature to support not getting up in the middle of the night, but it's certainly not an incorrect thing to do if there are any concerns. And then type 4, that would just mean it's so unstable that the normal means by which we do this surgery, which is flexing the elbow up and putting the pins in, doesn't actually work, because the fracture fragment will flex when the arm is flexed. So then a lateral x-ray actually needs to be taken of the arm with a cross table type lateral. So it makes doing the surgery just a little bit more challenging, and these are fairly rare fractures as well. In terms of pin configuration, most people do a lateral pin configuration because it provides enough stability. It is not as strong as doing cross pins. So at least for me, I would always do the lateral pins first. And if there's some residual instability, then I would put in a medial pin, but that's really probably only a couple times a year. And the reason that people put the lateral pins in rather than the medial pin is because of the risk of ulnar nerve injury on the medial side. So generally speaking, we'll make a small incision over the entry point and use the small clamp or schnit to get down to the bone and make sure that the ulnar nerve is protected when placing that medial pin. Vascular compromise, we talked about this in terms of the examination, but it's very unlikely to have a true vascular injury in a supracondylar fracture, but I think it's always good to be aware that that is a possibility. I think that I gave a lecture to ER residents and fellows, and they felt the rate of arterial injury and supracondylar fractures was something on the order of 30 to 40%, but it is, less than 1%. So since I've been at MUSC, I can't think of one that we've required a vascular surgeon to come and repair an artery for us, even though we see a lot of supracondylar fractures. So most of these are tethered or kinked or in spasm. And so after doing a CRPP, then you can reassess, make sure that you have a pulse, that you have good perfusion, that you have good cap refill, that you can Doppler a pulse. Any thoughts on vascular compromise, or how do you call ahead? And then, of course, who repairs the artery can be challenging too, because many vascular surgeons don't feel comfortable repairing an artery in a young child. So often our hand surgeons or microsurgeons are the ones that would help with us if we need help. So most of these fractures as well can be treated by closed means or percutaneous pinning, but open treatment can occur when you have an open fracture, if you have a nerve or vascular entrapment, or if you most commonly just aren't able to get a good closed reduction because there's something in the way, whether that be periosteum, a neurovascular structure, some brachialis. But I think there has been good studies to show that pediatric orthopedists who do a lot of these do these a lot more frequently by closed means versus if an adult trauma surgeon is probably much more likely to open them. And that may be also because we sometimes do accept somewhat imperfect reduction. So it doesn't have to be absolutely anatomic, but it should be pretty darn close. So complications of supracondylar fractures, if they're not treated, we see this when I've been on mission trips or places where there isn't as good of access to care. You can get cubitus varus or a gunstock deformity. Compartment syndrome can occur, but again is quite rare in supracondylar fractures. Nerve deficits occur quite regularly, but usually resolve on their own, and stiffness is a problem. Generally just immediately post-operatively, but not long-term, as kids are amazing. And then there are rare instances of AVN as well. Any questions about supracondylar fractures before we move on to the forearm fractures? Okay. So forearm fractures are very common. They usually occur in both in the distal forearm most commonly, then the middle and the proximal, and that's good because the distal forearm has the most ability to remodel. Again, these are often just falls onto an outstretched extremity. The goals of treatment are to get the fracture to heal and to preserve function. And then part of this is cosmesis, as you can have a very crooked arm if you don't have appropriate treatment, but unlikely here in the United States. So again, knowing what the physes look like and that the distal physis is where 80% of the forearm grows, that means that distal fractures can have a lot of potential for remodeling. This is probably just some good things to think about, that there's thick periosteum, so that helps the fracture stay in kind of the right continent, you might say. There's a mechanical stability, rapid healing, remodeling, and it affects your reduction maneuvers. So this is something that as a medical student, if you can get down to the ER with some of your resident friends and practice doing some reductions or seeing how they're done, this is sort of kind of the fun part for the medical student, sometimes getting to be very involved in that and just thinking about basically where did the bone come from and where does it need to go back to. So we can think about the deforming forces. So the proximal third is supinated by the biceps and the supinator, and the distal third is pronated by the pronator quadratus and the brachioradialis. So just having those things in mind or being able to answer those questions can be good. And then maybe to a medical student who's listening, where could you accept more deformity, if the fracture is near the wrist or if it's near the elbow? Deformity is allowed distally, and that's because the distal radius and ulna do a lot of the growth. So the closer you are to the growth plate, you can it will remodel as the patient grows. So the younger the patient is, the more deformity you can allow. And I think you said something good there about how much motion the joint has. Do you think that it remodels more in the sagittal plane or in the coronal plane? Okay.
Versus coronal.
Yeah, so you're correct. The plane of motion of the wrist and the elbow, there's a lot more correction that can occur there. So usually we would allow much more deformity in the sagittal plane. Terrific. Well, so this is just a nice example here in this picture of just seeing that amazing remodeling potential that pediatric patients have. Here we're looking at a sagittal x-ray of the wrist that we have up here. So that would be the flexion extension plane or the plane of motion. And so that remodels well the coronal plane. So if we were looking at your hand, I guess, flat, or, if you're just the opposite plane or would be varus valgus, and that would not be as well tolerated. Although I don't know, you wouldn't always use that term, I guess, in all parts of the body, but yes.
Okay, gotcha. Thank you.
Okay. So I think we've already talked a little bit about how much remodeling can be expected. So also how much shortening is allowed is another consideration. So bayonet apposition, or meaning the bones don't actually touch but are overlapping, is we consider that acceptable if the patient is less than 10 years old. And again, rotational deformity doesn't remodel with growth. Okay. So assessing rotation, sorry, this got covered up a little bit, but you can look at the radial styloid and the bicipital tuberosity, and they should be 180 degrees from each other. So you should be able to see them here on the same x-ray to make sure that there isn't a rotational component of the fracture. So that's a good one to know. And then what is acceptable if you're less than 8 years old? We usually say 20 degrees of mid-shaft angulation. Bayonet apposition is okay, but no rotation. And if you're greater than 8, you can have up to 10 degrees of mid-shaft angulation. That would be the radius and the ulna.
Hey, Sarah, what is bayonet apposition?
So that's a good question. So yeah, that would just mean I don't have a great, so this is almost a picture of it here. I was just thinking there would have been nice to if I had put a picture there, but there would be so much shortening that the ends of the bones overlap each other. Okay, so there really isn't a non-union simply is not really going to occur in kids, but a malunion is what we're trying to avoid, which would be too much angulation or too much rotation. But usually shortening or that bayonet apposition is not a problem. So just a few tips that I'm sure your residents will love to give you when you're trying to do a closed reduction. First of all, make sure the patient is comfortable enough to do that. And I would actually say that still remains one of the challenges for our junior residents. You want to not push too hard on the ED. And so it can be challenging to do this if the kid is screaming or their mom is crying or there's, too many the patient is uncomfortable. And then usually we will try to recreate the deformity, provide some longitudinal traction, and then reverse the deformity, provide a 3-point mold, which we can talk more about, and then immobilize in either a well-molded cast or a sugar tong splint. Oftentimes we try to encourage our residents to cast. I don't know if Jason, you have other thoughts on that, simply because then they don't have to come back to clinic and be changed into a splint, although the splint does allow for some swelling. Absolutely. So some casting pearls here. You don't want to have a bad cast because that will not hold the fracture, even if you get a wonderful reduction with a really sleepy patient and you have awesome x-rays to show at fracture conference. If the cast is poor, the fracture will look like it did when it came in when it comes back to see you. So the 3-point molding that we talked about, which means basically you want to, for this fracture we're looking at here, you'd want to basically put your knee underneath the fracture and then push the arm down on each side. So you have 3 different points there to basically create the forces on the fracture. You want to provide an interosseous mold, which is well shown here, which means a nice tight cast index, which that just means that the cast is narrow, it's not big and fat. You want to have a straight ulnar border. You need to have the elbow nicely at 90 degrees. And as this is Rob's slide here, no banana cast or something that looks like a banana. It should be a crisp looking cast to be able to hold the fracture. So when we talk about any more thoughts on casting, you're going to be, if you become an ortho resident, you'll be excellent at this. There'll be lots and lots of opportunities to put on good casts and splints. So it is okay to put on a cast acutely in the eyes of, I think, all pediatric orthopedists. It just needs to reduce that pressure by valving the cast or cutting the cast to make it no longer a truly circumferential immobilization device. Yeah, good point, Jason. And I think that, yes, if you're trying to monitor for compartment syndrome, it can be harder to do in a cast as well. So classification of these fractures, we sometimes talk about plastic deformation, green stick or complete fractures. Plastic deformation is usually a minimal deformity and the bone actually just looks a little bit curvy, and there can be some bowing there. Usually if there's less than 20 degrees of angulation, it will remodel, no reduction is necessary, and it can just be treated with a cast, or if there is more deformity, it can be treated with a closed reduction and a well-molded cast. Green stick fractures are incomplete fractures. Some people call these buccal fractures. One cortex is fractured and the opposite cortex is intact or without plastic deformation. Many of these can be treated with a closed reduction and well-molded cast. So the treatment, again, as you're hearing for all of these, is pretty similar. And a complete fracture, again, if it's non-displaced, can be treated with a cast, and if it's displaced, again, required closed reduction or splint immobilization. Surgery for forearm fractures, we do that if they are irreducible or unstable. And interestingly, many that look good at 1 week can still fall off in the weeks after. So we do follow these closely to make sure that they don't fall off or lose the reduction that was achieved acutely. Open fractures are treated operatively, or there's some controversy over the poke hole type of fractures that we could spend a lot of time discussing, but most of the time an open fracture would be treated with surgery. If there's a vascular injury, a multiply injured patient, a floating elbow, or a refracture. Okay. We'll just touch briefly, as I know we're running out of time. The surgical techniques here are usually intramedullary fixation, or people call these flexi nails. And so they almost look like coat hangers here, or it can even just look like a big K-wire or Steinman pin that's inserted distally in the terms of the radius and proximally from the ulna. And sometimes only one bone needs to be fixed, but this is actually a fairly small percentage of forearm fractures that require this. And then in those that are near skeletal maturity, we will do the same thing that we would do for an adult forearm fracture, which is a plate and screws. And that's because we want to restore that perfect rotation for supination and pronation. Okay. All right. Any questions about that? And then we'll end up on distal radius fractures. Distal radius fractures often occur in a little bit older patients, and they have an excellent propensity to heal. Again, because this is close to the physis, and this is the physis that grows a lot, they have a lot of potential for remodeling. What is acceptable if you're less than 20 to 25 degrees of angulation in the plane of motion, or the sagittal plane is okay, and up to 50% translation. If you're more than 12, then usually 10 degrees of angulation and 10 degrees of radial ulnar deviation. And again, we talked about looking at the radial styloid and the biceps tuberosity to figure out the rotation. Okay. We have distal metaphyseal fractures, buccal fractures, bicortical fractures, or physeal injuries. And these torus fractures or buccal fractures are very stable, and they can be just retreated with a removable wrist brace. Metaphyseal fractures are similar to how we would treat a both bone forearm fracture, where you're going to actually do a reduction and a mold. And the cast will usually be a long arm cast. If it's more proximal for a distal radius, it can be a below elbow cast. Okay. And then short versus long arm casts. This is for distal third in the forearm. This is, I think, just something good to have in your back pocket, so you can maybe speak at fracture conference if you're getting called on, and that you have a good cast index. There's no difference between short arm and long arm casts. Okay. And this was a paper actually done in Minnesota. No, this was not. This was, sorry. This is 102 patients. They, again, showed no significant difference in short arm or long arm casts in terms of manipulation, but a higher risk of higher risk of remanipulation for radius and ulnar fractures and angulation after reduction. So we can get contrary results depending on what you're looking at. Bicortical metaphyseal fractures, again, you may end up doing some pinning for these. And then surgical indications are for unstable, irreducible, open fractures, or floating elbow. And then physeal injuries, you can immobilize the non-displaced ones, but we will do a closed reduction for any displaced physeal injury. And you just want to be gentle and not do too many manipulation events through the physis. Really, though, growth disturbance, interestingly, is quite rare, even with the very displaced physeal injuries. But you do want to see these patients back to check and for growth arrest, even though it only occurs in about 3 to 4% of fractures if it's a high mechanism of injury. Okay, so we're here to our summary slide that pediatric forearm and distal radius fractures are common, and they can be treated with closed reduction and mobilization. And then just kind of know those parameters about what is acceptable for the fracture, and think about length, alignment, rotation, just like in any bone in the body. And then also good to know the indications for open or percutaneous treatment of forearm and distal radius fractures.